Hello, everyone. My name is Shadi Yaghi. I'm a vascular neurologist at Brown University, and I'm the writing group chair of the scientific statement, Treatment and Outcome of Cervical Artery Dissection in Adults. In patients with cervical artery dissection, we know that the risk of ischemic stroke within 180 days is about 3.5%, but the majority of these strokes happen within the first month from diagnosis. So, what do we do to lower the risk of stroke? Our general practice is to use antithrombotic treatment. And there are two classes of antithrombotic treatments that have been studied in cervical artery dissection: antiplatelets and anticoagulation. And studies comparing antiplatelets to anticoagulation in patients with cervical artery dissection, these studies yielded mixed results, thus leading to variability and equipoise in practice. Both studies were underpowered to detect a statistically significant difference in outcome between the two treatments. And a meta analysis that combined the two trials showed non significantly lower ischemic stroke risk with anticoagulation compared to antiplatelet. But on the other hand, it showed non significantly higher major bleeding with anticoagulation compared to antiplatelets. In this statement, we suggest that provider consider an individualized treatment approach. If they're high-risk patients for ischemic stroke, it would be preferred to treat them with anticoagulation. But those who have a lower risk of ischemic stroke, it would be reasonable to treat them with antiplatelets. Also, when deemed safe, we suggest considering dual antiplatelet therapy with a loading dose instead of antiplatelet monotherapy, and this is to optimize the antithrombotic effect early on when the risk of stroke is highest, particularly in those patients who would otherwise qualify for minor stroke and TIA trials, chance and point that show the benefit of dual antiplatelet therapy over antiplatelet monotherapy. This algorithm is shown in figure 3, so please refer to figure 3 for more information about the antithrombotic treatment algorithm that we propose in patients with cervical artery dissection. Um, Generally, we would consider antithrombotic treatment for 3 to 6 months from the diagnosis, but it could be continued beyond that in patients who have an increased overall cardiovascular risk. For example, those with a history of myocardial infarction, those with atherosclerotic disease, or those who have other indications for antithrombotic treatment. On the other hand, stenting of the dissection could be considered as a secondary prevention strategy in very rare situations, those who have impaired distal blood flow and also have recurrent ischemic stroke despite optimal medical treatment.